Well, good morning. Behind me are a bunch of medical offices, and a whole bunch of people, patients, walk into these offices every single day. And unfortunately, from the doctor's perspective, everyone kind of is the same. They've all got the same, relatively the same issues, cold and flu symptoms. It's that season. I know I'm a little bit congested, so is my daughter. But from a doctor's perspective, from a staffing perspective, a lot of patients are getting treated in the exact same manner. The runner who loves to go out on the trail and is really geeked out about her shoes, and she's going to approach her healthcare a little bit different than, let's say, the grandma. But yet, we as patients are treated the same when we walk into a healthcare office. So what if I were to tell you that there's this thing called patient psychographics and patient segmentation, and we can determine through marketing and through analysis and through statistics and data. I love data and I love the evidence behind it. We can really choose from a healthcare, if we are working in a healthcare sector, we can choose and motivate people to come into these offices behind us who fit our niche. So if I'm a sports and healthcare doctor, and that's the type of patient I want, then what if I was to just send out a postcard to, let's say, 3,000 people and hope that I get all of the sports people, the runners and the athletes and the marathon people? Well, that's not likely going to happen. But I want you to listen and lean in to my good friend Casey Albertson. He's got something to share that he shared with us at the 2018 Concierge Medicine Forum just a couple of weeks ago, and I think you're really going to like it. He's going to talk about patient segmentation and psychographics. He's going to talk about the behaviors that motivate patients, and there are 5 of them. So listen in, and I'll see you at the very end.
I'll hide behind the TV.
Yeah, that's it.
So you can bring up the big screen there. Thank you.
Ladies and gentlemen, have we got a treat for you? Our next speaker, I am confident, is going to be somebody who inspires you, brings you new information, some areas that can help concierge practices in the future, but also some ideas and things that can help your concierge practice immediately on Monday for how to engage new patients and how to engage patients who are in your practice as well. It's my privilege to introduce the speaker because I've known him for probably over 2 decades. Casey Albertson is somebody I first met when I worked back at Procter & Gamble, and Casey was already a legend at Procter & Gamble in healthcare. He ran huge areas of the healthcare business, connecting with the emerging managed care markets, and the way he got in and got so much influence over those managed care groups was by building some proprietary excellence in understanding the consumers, the patients, and how to understand and differentiate them based on not just their demographics, but also their behaviors and their psychographics. And what's great is that Casey knows the concierge market very well because he's worked in that area as well for several years, and now he's focused exclusively on this demographic and psychographic type segmentation. Is going to share some of that with us today. So as you eat and enjoy your lunch, I'm thrilled to introduce to you a good friend of mine, Mr. Casey Albertson.
All right, we are going to talk a little about psychographics. And I first want to give Dan a hearty thanks. I had not seen him for several years. It was fun to see him at the conference again. Because Dan was one of those people at Procter & Gamble who was what we call a visionary. So he was often seeing consumer trends long before anybody else in the company did. And in the whole concierge space, Dan was really instrumental for the company to get involved. And so when he sat down at my desk one day and said, hey, I think I'd like you to move to Florida. And I said, well, I've got to talk to my wife. He said, good news, I already have. And so my wife knew about the move to Florida long before I did. But Dan's always been a visionary in this space, continues to be. We've been getting caught up here over the last few days. It's been really fun to see him again. So thank you, Dan. All right, so psychographics. At the end of the day, psychographics is about understanding deep-seated motivations of why people do what they do. Everybody talks about behavior change, and there are a lot of companies and a lot of technologies and a lot of people that talk about it. But if you don't understand the motivation of why somebody's doing what they're doing, which is based on early imprinting from age 0 to 18, what happened to them during that time, you really don't understand how to change behavior. So today we're going to talk about psychographics, we're going to talk about what is it, the research process, who are these 5 segments that we uncovered, what have we been doing over the last 6 years from a case study standpoint, to prove out patient engagement and outcomes and acquisition of new patients, in keeping patients loyal. And then we're going to flip to how does this affect the concierge practice. So anytime, when you're 22 years old and you join the Procter & Gamble company, the first thing they tell you is you can't just go out and invent something. You have to assess the landscape. What's going on in the marketplace that would say whatever your product or service is, which in my case is psychographics, how do we know the market cares? How do you know there's a market need? And so the first thing I did was just start to pull up some different data around providers, payers, pharma companies, employers, and all the different types of things they were literally thrusting at patients. Some of them were 100-page brochures, some of them had money involved, some of them had incentives involved. It's basically, I can tell you that the healthcare consumer is confused, and for the most part, they get message fatigue and shut down. And so when we started this process, we did some large market research projects, which I'll show you about. But one of the stats from our market research is this first one. We asked the question, and we have 1,200 different attributes on a healthcare consumer, but one of the questions we asked was, do you consider yourself a couch potato? 25% of the United States population on a 5-point scale answered strongly agree or agreed to that statement, which kind of was alarming to me. But because I have 15,000 people in these studies, I can sub-segment and say, well, now I just want to go look at cardiac patients. How did people with known cardiac disease answer that question? 34% of them said they're couch potatoes. So even people who are sick don't necessarily do what they got to do to be healthy. So that was one of the first insights we had. Now, those of you that are clinicians, you kind of already knew that. But it's one of those things we had to go prove to go, if we're going to spend all this money to figure this out, is there a market need? The second data point I love, and this came out in the JAMA invited commentary last spring, I think, about a little over a year ago. Caremark did this study on medication adherence, 54,000 people, test versus control. It was a well-designed trial. They picked 3 of these digital doodads to help people remember to take their medicine. And at the end of the trial, what was the result on impending change in medication adherence? 0%. 54,000 people, well-controlled study. This thing got buried faster than you can shake a stick because all the tech companies didn't want you to see that all this technology stuff that they do isn't working. And so we kind of said, okay, now we know what's not working. Let's start to look at the marketplace. And I love this cartoon because as you look at healthcare, what we tend to do is to say, okay, I've got a cardiac patient, a diabetic patient. We're going to do this. Here's the material we're going to use. And in essence, do a one-size-fits-all. Well, I love this cartoon because you've got 4 different, very different shaped animals standing in front of a clothing store that says one size fits all. Now we can all kind of look at that, laugh and chuckle and go, isn't that a cute cartoon? But now let's step back and look at our daily practices and go, if I have a diabetic patient, am I doing the same thing the same way all the time? And what I'm about to show you is there's 5 different ways to get after this based off the research. Now, what Dan will tell you, once you leave P&G, you're an alumni for life. I'm still pretty involved, and I still use a lot of the processes and techniques. And one of them is called the brand building framework, the who, what, why, and how. If you understand those 4 things about a consumer, I don't care if you're selling trucks, selling concierge medicine, if you're trying to get people, to buy into an app, if you know those 4 things, you can position your product or service in a way that will get people to buy into the value proposition. Now, the reason I colored the who and the what green is because healthcare, by and large, already does that pretty well. So from a demographic standpoint, for 20 grand, you can buy a pretty good demographic study that tells you who are the people that are in my geography. You can get the age, the race, the gender, the income, all that stuff's pretty available. The what is the behavioral components. So there's thousands of population health companies. There's all kinds of data that's available out there that says, on average, patients that have diabetes go to the hospital or go to the doctor 3.8 times per year. They go to the hospital once. Their expense is $4,200 a year. That's all behavioral segmentation. In a form, artificial intelligence is behavioral segmentation, because what they're doing is using data from the past to try to predict what's happening in the future. So as you move to the next levels of consumer understanding, and understanding the why, as I mentioned, this is about the early imprinting. What happens when we're young that causes us to do what we're going to do when we're older? So I'm going to show you this 5 psychographic segment model, and from the time we're 18 until the age that we die, whatever age that is, 90% of us are never going to change our psychographic segment. So that's the why. Now, our behaviors can change all the time. With the advent of the Affordable Care Act, urgent care, less doctors were practicing, urgent care took off. More people started going to urgent care. Behaviors are always going to change, but the root cause of what gets people to do what they do fundamentally doesn't change. The last part is how. How are we going to reach these people? Is it email, is it text? Do I have a case manager? Do I get involved as an individual? Do I bring them into the office? If you don't know the why, you're kind of guessing at the how. And we're doing a lot of guessing in healthcare. So what we did with this psychographic research projects was to start to go, what is the chemical DNA of why people would do what they do in healthcare? So you're going to see here, and I'll go this way, we did 3 studies. The first one was in January of 13, we did one in January of 15, and we finished one just a couple of months ago. The base size of these studies are pretty large, 4878, 4039, and 4105. Along with my over quota sample, I have over 15,000 people have answered 380 questions over the last 6 years. Now, I did not do longitudinal data, and there's all kinds of reasons I didn't need it. I did trend data. What I wanted was different consumers from different points in healthcare after the Affordable Care Act to answer the same questions to see, do my 5 psychographic segments answer the questions the same way? So if you look at January of 13 and January of 15, there's one thing that happened in between those 2 studies that will probably never happen again in this country. And it was the launch of the individual mandate. You get to choose your doctor or lose your doctor, depending on which one it was. Your health plan changed, your deductibles went up. And everybody's like, everything's going to change, healthcare's going to change, consumers are changing. How these 5 segments answered the questions on either end of that event did not change with respect from the fundamentals of why do they do what they do. Now, interestingly enough, we've done some work in dental. I'm kind of a big mind, body, spirit guy, so we did a study on religion and what does faith play into healthcare, which I had another hour, I'd tell you about that. It's a pretty fascinating project. We've done a bunch of things on food. We're getting involved in several other areas. And what that all says is I'm pretty sure I have a universal segmentation model. So even if Ford called me, I'm pretty sure I can use this model to help sell trucks. But right now, our focus is on healthcare. So these boxes down here below, these are just, and I'm sure you can have access to these slides, and that's kind of small print. But those are the subtopics of all the questions that we ask. So there was a lot of different things we dug into. Now, there's something called, for those of you that are stats people, when you look at a giant database of 15,000 people, they answered 400 questions, there are 150 million data points. We use Ipsos International, a giant global market research firm, and they did something called factor analysis, and then they did the statistical clustering procedures to see what was the smallest subset of questions we could get to that would clearly delineate that somebody was in this group versus that group. So if you go to our website, it's a 12-question classifier. It takes 90 seconds. If you answer those 12 questions, you're going to fall into one of these 5 groups with 91% accuracy. So now you say, well, that's pretty cool if I got somebody in front of me. What if I'm trying to, I deal with a lot of large hospital systems and HMOs. Well, we got 4 million people, and I got 40,000 people who are overdoing a mammogram. I can't send them out 12 questions. Well, everybody's heard of these large data compilers. The most notable one's Experian. Everybody knows your credit score. Well, there's a reason they know your credit score. Because you lay a digital footprint every day about what you're doing. Every time you use your credit card, every time you save 10 cents on hamburger, they sold your data for 20 cents. There are profiles built on every one of us that are for sale every day. I use a company called KBM because they're pretty good at healthcare. They have 700 attributes on 230 million Americans in the US over the age of 18. I took my 15,000 people, I found them in their database, we wrote an algorithm, correlated it. I can now segment this whole room without you even answering the 12 questions. If I have your first name, your last name, and your home address, I can tell you which one of these 5 groups you're in, which allows us to do some pretty cool things when you start to think about marketing or affecting clinical outcomes. So let me tell you about the 5 groups. This first group is called self-achievers. So they are about 24% of the population. Let me get back. This is the patient we probably wish most of the population was. This is a go, fight, win. They take ownership of their health. They keep track of things. They're the ones that bring in their medicine bottles. They keep a diary. So in a clinical study, this is the group that does very good at following the directions. When I ask the question, is the doctor the most important resource for my health and wellness needs? 78% of them strongly agree with that statement. And it's statistically significant versus the other 4 groups. The second is sort of highly proactive, and I organize these from highly proactive to highly reactive. And the names are just names we gave them. They're not really meant for public consumption. I came up with a noun and an adjective that in 2 words kind of described who they were. So even though you don't have the 150 million data points, self-achiever kind of tells you who they are. Balance seeker, also highly proactive. But when I ask that question about the doctor, only 19% of them agree with that. This is a group about options, choices, context, understanding. I can almost close my eyes, and every time somebody's asking for a second opinion, it's probably a balance seeker. This is the group that comes in with the dozens of internet articles, has already figured it out, and they're just looking for a verification from you. And when they ask about alternative medicine, we might tend to go, that's hooey balooey or whatever we might say. Well, this group's going in the back of their mind, I didn't say I was going to use it, I just wanted a good opinion on it. The fact you won't give it to me discredits you, therefore I'm going to leave this practice and go somewhere else. That's what happens in a synapse with a balance seeker. Priority druggers. I know this group pretty well because I'm in this group. This 18% of the country, this is the group that literally does not care about their own health care. But when you invoke the family, when you invoke sense of duty, responsibility, people depend on you, this is how you appeal to this group. Direction takers, kind of exactly what it says. Just give me the 3 bullet points. I don't want to I do not care about how the kidney works, I just want pee again. All right? Now, you can't sit here and say, oh, this is a not educated group. My little brother has, advanced engineering. He manages a plant for one of the big aluminum companies. He's a direction taker. He's got about twice my IQ, and he's like, I'm not a direction taker. I said, well, Mike, when you had that car accident, he goes, yeah, these doctors kept trying to tell me how the elbow worked. I'm like, I don't care if you put coppers, just make it work again. I said, well, Mike, that's what a direction taker is. So for those of you in practice, you're already seeing, all 5 of these people are going to show up every day. The last group is my favorite group for a couple of reasons. One, it's the largest group in the U.S. It is the hardest group to move their mind, and I'm married to one. I haven't yet got into the marital advice of how priority juggers and willful endurers, but my wife and I are pretty sure we could write a book on that topic. But willful endurers, we named them that for this reason. I can will myself through anything, I can endure any pain. This is the patient at 45 years old. When they show up in your office, you're like, how come I don't have a chart? How come the hospital doesn't have anything? It's the first time they've ever been to a doctor. All right, this is the group that waits till the absolute last second, and when they can't take it anymore is when they finally go. And so if you look at the growth of urgent care, I'm going to show you some data here a little later. 67% of all urgent care visits for the frequency of 1 to 3 months are from this group. And so if I'm building an urgent care center, there better be a whole lot of these people within a 5-mile radius of me if I think I'm going to be successful. Now the reason they use urgent care is this. I'm finally ready. They dial the phone. Well, how about a week from Thursday? How about right now? They hang up the phone and they go to the urgent care center. So as you look about how do I influence this group? Goals, winning, attributes. We have a plan. Balance Seekers is about choices, options, context. Well, I was a doctor, I had a new diabetic, and I'm not a doctor, and I had a new diabetic patient, and I had him in front of me. I'd say, hey, we got a couple of choices here. One, if you want to keep eating the Big Macs and Coca-Cola, I'm going to have to load you up with the drugs. But if you want to be drug-free, we got to get off the Big Macs and Coke. Which one's a better choice for you? This group will fall down and say, finally somebody understands me. The other four groups were like, I thought you were the doctor. All right, so it's just, again, these two groups are very proactive, but they go at it very differently. And so those are, and as we look at priority jugglers, it's interesting. When I got and did the religion piece, I found a lot of corollaries to healthcare in that fear and guilt seem to be two things that we use a lot in religion and healthcare to try to motivate people. Fear and guilt works exceptionally well with this group. My own concierge physician knows I'm a priority juggler. And he said, Casey, time for a flu shot. And I said, why? So I can get the flu? Get the damn needle away from me. And he said, Casey, you have this company. You now have 48 employees. Do you know what would happen if you went down for a few days with the flu? Give me the stupid shot. And then after he gave it to him, I said, hey, you're using my own stuff against me, aren't you? And he just kind of chuckled and said, this stuff works. Direction takers, keep it simple. I'm going to go back to priority jugglers for a second. This is the group that also comes in and says, hey, Sysmax is the one that I need. So as you're looking at your day, and again, concierge medicine, we're not always concerned about, 15-minute visits. A lot of times, my annual checkup is always a couple hours. But this is where you pick up a little time. Because if you go back to the old days of medicine, the cough cold were the people where you picked up a little time. Oh, I'm glad it's not a cardiac patient. I got a cough cold, I can pick up 10 minutes. You can pick up 10 minutes with a priority juggler. They don't want to know, they want the answer. They want the script, they want to move on. The direction taker is something that's also going to put you on a pedestal. This is just, what's the 3 things I need you to do? And this is the group that you say, I want you back here in 10 days, they will be back in 10 days. Wolf-Linders, the whole focus is here and now. If you've got a 10-step plan for better cardiac health, this self-achiever is going to want to see all 10 steps. They're going to know the time commitment. They're going to want to know what they're going to do. Do I need to buy a Fitbit? How much is it going to... You're going to lay it all out. You do that to a Wolf-Linder, they'll never show up to the first session. A Wolf-Linder is, here's the first thing we're going to do. And it's all we're going to worry about. Once we complete that, if that works, then we're going to worry about the next step. Now, it's kind of fun. I'm in some pretty big institutions with thousands of doctors. Like, how are we going to train the doctors? You already do this stuff. There is nothing new. Everything that I've just shared with you is something all the clinicians have already done. All we're doing is compartmentalize it and saying if it's a balance seeker, this is the right methodology. So my physician training program in large institutions is 10 minutes long. I'll get a group of 50 doctors, and about minute 11, I'm like, I'm done. Is there any questions? And they're like, most of them go, I think we can do this. And after about a week, most of the doctors go, oh yeah, Miss Jones, she's a balance seeker. I already know that, I don't have to test her. And that's what's kind of fun about this. The magic in this is not the secret, the code book. We give away the code book of what you do with these people. The secret is knowing that Dan Hecht is a self-achiever. And if I'm a priority juggler, what do I got to do with the self-achiever to get him to do what I want him to do? Well, I wasn't very good at that through all the years. It tended to be the other way around. But those are the 5 segments. Now, what's interesting, what's different than demographics or socioeconomics, all 5 of these segments are in every population. Doesn't matter, just the distribution is going to be different. So if you look up here, at the general population, that's the percentages I gave you just a couple of minutes ago. 18 to 24, 40% are Wolf-Linders. So if you think about Wolf-Linder, here and now, immediate gratification, not worried about tomorrow. We know this group is the smoking group. We know that they're the drinking group. We now know that they're, based off this last study, they're 3 times more likely to be the opioid abusers. What do we do to connect with them? Everybody goes, well, that's the millennials. Well, that's 40% of the millennials. We can't block generations together and say, this is how they think. Now, 40% of them think like that, but the other 60 don't. So even as you look at Hispanic, even as you look at Medicaid, uninsured, you're going to see the distribution changing. Now, I'm going to show you a case study from readmission, which is not completely applicable to here, but it is clearly a passion area of mine, because I think it is a crime that we have somebody in the hospital, we have surgery, we discharge them, and 25% of them come back in under 30 days. Now, you hope that isn't financially motivated, and there's the penalties now as we move into value-based. There's a lot of systems. There's one big one in particular that's like, we want to wipe this out. But if you look across in the method, you have COPD, heart attack, hip and knee, look how big the purple bars are. All right, so my first case study that I'm going to show you is from St. Thomas, which is an Ascension Hospital in Nashville. Their discharge booklet was 62 pages. It was from HealthWise, very good stuff, technically accurate. And I said, hey, do you want to know which one of my 5 segments are going to look at 62 pages when they're having a little trouble breathing versus calling 911? None of them. This is completely off the mark. This is not only off the mark for one of them, it's off the mark for all of them. Any of us that have ever been discharged know the nurse highlights 2 things, and most of it drops in the garbage on the way out. So what is it that we're going to do to fundamentally change that behavior? So that's some of the things we got after. All right, one quick data point on each of these groups to kind of demonstrate who they are. So this first question is, my doctor is the most credible for my health and wellness needs. And I'll just explain this data a little bit. So the first one up here, that's the base size of the population of the study. Anybody that knows and does market research knows you only need about 700 people to have a nationally representative study. And in most presidential populations, or elections, not this last one, you could do 700 people. You're going to be pretty close, plus or minus the 3%. Obviously, that didn't work on this last one. Ours are 8 times the size of what we needed because we wanted a national rep sample of over 700 in each group. I can cut these groups by 41 different diseases. I can look at anxiety and self-achievers and tell you what's their preferred vehicle to learn by, what are the colors they use, the words used, the frequency, what are the different ways we connect with these people. So that's the first line, is the base size. The little letters underneath just identify the category where we do statistical significance calculations. So if you look at this first one, my doctor is the most credible. Off to the right, you'll see direction takers, it's 90%, so either agree or strongly agree with that statement. You'll see it 148, that's an indice, so it's direction takers are 48% more likely than the general population to agree with that statement. And then you'll see all 4 little letters underneath it. Oops, wrong one. You'll see all 4 letters underneath it, which means it's statistically significant at a 95% confidence interval with a p-value less than 0.05. So again, one of the things you learn at Proctor is you better have the data. So data is always one component, and then have you proven it in market is the second component. I'm going to get that in just a second. So we know when we ask the question about the doctor, look at the range, 21 to 90. Again, as healthcare, we tend to lump people together. And there's a pretty wide variance on just that one question. I consider myself a couch potato. You can see the Wolfland-Durr, 38% strongly agree with that statement. Stat sig versus the other 4 groups. Now the good news is 62% didn't answer that way. Don't let sick get in my way of work. That is the priority juggler. You've all seen people that have come into your office or at your place of work and they're coughing and sneezing, you're like, man, I just wish I'd go home. But when somebody else gets sick, so they're the first ones to go, oh, you better go home and take care of yourself. Because the priority juggler thinks the world can't rotate without them being there. Their dedication to work and duty, sense of duty is so strong that they just don't miss work. I'm successful at maintaining nutritional habits. Look at the self-achievers off the chart. The indices are strong, the stat sig is there, and then the last one here, I'll do whatever my doctor tells me, which a lot of people like, but if you look, again, the range is 29 to 74. Now, again, you're going to get these. I just want to make a couple points. There's a lot of data here, but at least it's a little bigger in font size than the previous chart. These first 3 are about the doctor. These next 3 are about alternative medicine and other resources. So as we looked at this top one, you already saw, doctor's the most important resource. I like this one. I'll go to the doctor at first sign of health concerns. Well, look at my group. Out of 712 people, only 21 of them agreed with that statement. Balance seekers, it's only 5%. So right away you go, oh, there's some commonalities amongst balance seekers and priority jugglers. Well, let's get down to the alternative medicine question. I prefer alternative medicine to standard medical practice. 0% of 712 people agreed with that statement. So as you think about your practice, and you think about, hey, I'm going to introduce acupuncture, I'm going to do this or that, and if half of your practice is this group, it has fallen on deaf ears. They don't want to hear it. My business partner, starting all this off 6 years ago, he is a balance seeker. 58% of them stat sig versus the other. So there are places where we're identical, and there are places where we are different. And that's where, in these code books that we create, and these workflows that we build, and how do you affect these patients, all of this stuff is built into it. You start to see, what are the two groups that love the doctor? What are the two groups that love alternative medicine? Now, telehealth, technology, Apple Watches. Up until about 8 weeks ago, I didn't have a lot of good data on this stuff. And it's like, okay, I've walked into different health systems where I've seen like 40 cubicles of these, private centers for people to sit there and do the telemedicine. And they're often empty. And there's maybe only one or two. I've got 40 cubicles and you got 3 people talking. Why did you build all this? So we studied it. And what we found, on aggregate, only 5% of the US population has ever used telemedicine in the last 12 months. But you can see there's a variation. So the most proactive group, and again, the most reactive group, remember, this is the group that calls the doctor. If you don't have an appointment right now, they got to do something. So it kind of makes sense that they are statistically significantly greater. But it's still in single digits. Well, once we pulled out this data, the first client was like, yeah, but that was last year. Next year is going to be different. Technology is going to take over. Well, we studied that too. In my little block, but anyway. For some reason on the slide it got blocked out, but on yours you'll be able to see it. It only went up a couple of points. So even look at, Amazon Alexa. It is still 11 to 16% of people who say, I'm going to use that next year to help manage my health care. Look at the Apple Watch. Genetic testing, it was a little higher. Health portal was the highest. Online health community. Smartphone apps. Before you go putting $100 million into a smartphone app, I would think twice. Because while they're very popular in healthcare to manage their health, all 5 of these segments, for the most part, are in single digits. I think there's 30,000 healthcare apps that are out there. If you ask, I was at one, we rolled this out to 1 million people. How many users? Over 1 million people saw our ad. Great, advertising is great. How many people downloaded it? 17,000. So you got 1.7% adoption. Well, yeah, but we're doing these changes. So just, apps have a place, but for the most part, what we know from all 5 of these groups, it is just not a preponderance of something they do today. It's not that they won't 2 or 3 years from now, but as of today, they're just not. So, getting into the practical applications of this. Like I said, there was a couple of us started this in 2012 from the psychographic component. There was a technology group in Chicago. There's 4 or 5 of them, and we kind of merged the 2 companies together to become PatientBond in 2014. But the first thing we had to figure out is, okay, how does this work? We got data, and what any P&G'er will tell you, there's 2 things you have to prove. Find the data that says it will work, and then go out and demonstrate that it will work. You got to have some proof of concept in market before you launch something. Now at P&G, sometimes we were second to market because of that, because we were slow on the testing. But I can look back through my 20-year career, and it's kind of hard to find any mistakes. It's not that they weren't there, they just weren't real visible to me. So this first one I'm going to show you is around heart failure. And again, all we did was to take, okay, we know there's 5 psychographic segments, and so we created a different workflow for each of the 5 based on words, images, frequency, the duration, the media choice. We created 5 different pathways for these 5 different groups. The automation, automation for automation's sake, you can buy it at the drugstore now. You can buy a text app. It's not that hard to do that. But we built a platform that can do it 5 different ways. And then what you do with that is you start to take it into market. Well, what's interesting, after this, as we started getting into this, the American Heart Association now endorses and actually builds our cardiac readmission programs with us. So we use all of their content. But what we did with them is we built 3 programs. Now what's interesting, the Health Enhancement Program is an app. And I have all the data on the apps. And they're like, hey, Casey, we got to build an app. I'm like, I'm kind of the wrong guy to talk to. Because I don't know what the adoption is going to be. Well, we have clients, we have employers, they want an app, we're going to build one. All right, I'm going to build you one, but I'm not sure what the uptake's going to be. And the uptake hasn't been real great on that one. But we built a condition management program. So I'm doing something at a large institution right now in AFib for 6 months post-discharge. What can we do to get people to stay healthy? And then the readmission reduction program is something I've been pretty involved in. So our first project a couple years ago was at St. Thomas, that I mentioned, in Nashville. They had about an 18% readmission rate. In the nation, it's 24%. It still is around 23.5%. It was 24 at that time. They were at 18, and they said, Casey, thank you for stopping by, but we're 25% better than the nation. We put all these programs in place, and thanks. You know, we'll talk to you maybe later. And I'm like, but if I can take something that's already doing it really well and make it better, imagine what we could do for somebody who's not doing it very well. And so they kind of bought into that argument. We did a 5-month program, 315 patients went through it. At the end of 5 months, we had a 90% reduction. We only had 6 readmissions, where on their old readmission rate, they should have had 58. Now, depending on how you cost out a readmission, between penalty savings, revenues, it cost us just about $10,000. So we literally saved them $500,000. And what we charge for that program is $4,200 a month. And so if you save 1 readmission a month, it's a 2-to-1 payout. Well, we saved them 6 to 10 a month. So they were getting about a 6 to 10 per payout on this. But what's really interesting, any of us who have ever sent out emails, does anybody know what the email, I guess its ownership rate and click-through rate is?
5%.
It's pretty low. 5% is probably my click-through, maybe 10, 12% is my openership, which are metrics and they're interesting, but they actually don't prove it. You know, it's a good guide, but did the person do anything? I'm going to show you how we actually get after that. In this particular instance, we sent out 14 sets of communications. Remember, these are all people with heart failure over the age of 65. We sent out 14 communications of 315 people. 62% of them responded to all 14. Even we were like, holy cow.
Wow.
That's a little better than even we expected. And they're like, well, is this what you expected? Of course, but yeah, this all the research is exactly what we expected. But there's a lot of things that we learned through this process. Now, we tied this into a call center, meaning that in every email or text we send out, we require a response, meaning press 1 if you're feeling better, click this link if you've gained more than 5 pounds in a week. So we always require an action. So when I say a response, it's a response to how are you doing. That data instantly goes back into a dashboard where an office nurse or a call center can look at it and go, and it's real time, so literally, hey, 6 seconds ago, Casey clicked a button that said he's having trouble breathing. I better give him a call before he calls 911. So when we look at the 90% reduction, there's a number of things that went on in there. But again, back to that call center, if you think about, if anybody's ever done that, and you picked up the phone and tried to call somebody, what's your hit rate? Meaning you talk to a person. It's like 2 to 8%. Every phone call from a call center costs $14, and 90% of you get nobody. Which begs the question, why are you doing that? Which is part of my presentation when I'm out on the road. But what we found in this pilot, because people had responded and said, I want to talk to somebody or I'm having trouble breathing, 83% of the outbound calls had a first contact connection. So there's a lot of things we found out in this that were pretty cool. So the process was pretty easy. They agreed to it, number 1. Number 2, they look at all the materials. So all of the materials we use, I am not a clinician by training. I know a fair amount about cardiac stuff because of personal stuff that's happened in my life. I have a passion towards heart failure and trying to figure out how we can make that better, but I'm not a clinician. And that's why this relationship we have with the American Heart Association is pretty important, because all the videos, all the content, all the written words, everything's from them. And so we typically have the client look at that stuff, and then we implement it. There's 3 things you have to do to implement a program with us, so to implement the psychographics. 1, at discharge, somebody has to tell the patient about it. It's not going to be me. It's a discharge nurse, it's an office nurse. Number 2 is the patient is going to receive a series of communications, and I'll show you what that looks like, over whatever defined period, 30 days, it can be 6-month programs. And then we've got to connect back the answers to an office nurse, a discharge nurse, call center, and I'll show you some examples of how we did that. So we basically designed, what does the protocol look like? Again, I'm not a clinician. I sat with the medical director at St. Thomas. Her name's Teresa Herman. And she said, and we all know there's 4 pillars to reducing readmission approved by CMS. Go to the doctor, take your medicine, understand red flags and warnings, and be connected to the EMR. And if you look at this protocol, all 4 of those are actually built in there, but we threw in a few other things. Now, when you think about 5 segments and 14 communications, you're like, well, how do you do that? Well, it looks like kind of crazy on this chart, but remember, for somebody that's a balance seeker, they're going to get 14 communications that are carved out uniquely to them. When I set this up, it looks like kind of a discombobulated mess. But we have a workflow, depending on which segment it is, on timing, frequency, color, all the different things we talked about. So with discharge, all the person does, enter their first name, last name, put in a cell phone, and put an email, because somehow I got to get a hold of them. What we found is 35% of the phone numbers people put into this are not in the chart, or they're not in the EMR. So we did a little research on why. And we found out that, yeah, when they're trying to hunt me down for money, I tell them the number where they're not going to find me, but when they're trying to help me, I want them to call me over here. So most of the numbers we have in the electronic medical record are the "you're not going to find me" numbers. And that's kind of a fun side effect we found out about this. The next thing the patient does is they answer the 12 questions. 12 questions takes about 90 seconds. They're pretty nebulous. The first one is, do you think you can affect how long you live regardless of your family history?
Yes.
Yeah, I'm the same way. So right away, I know you're either leaning priority juggler or self-achiever. Just by one question, but there's 12. 12 questions with 5 responses. If you're good at factorial, that's 144 million combinations of how people could answer this questionnaire. And that's why I needed the IT guys. Most of our companies are actually people on the technology side. After they answer these 12 questions, we actually don't tell the patient what they are. We just give them a little thank you. They click a little button, check a box that opts in to receiving electronic communications. Another thing we found is pretty cool. Would you like a family member to get duplicate communications? Because some of these people were 85 years old. Well, we found about 40% of people filled this out. So I've got an elderly lady in Nashville, but now her son in Dallas is getting the same 14 communications. Hey, Mom, I just got something about medication. Are you doing it? So it's just another digital way to say, how can I help this patient do the things we know we want them to do? Next, we create electronic discharge, so all the things you would talk about, weight monitoring or diet and fluids, follow-up appointments, medication, all of that is in there. You get to design whatever you want it to look like. This is an example of a day 5 communication that we sent to a heart failure patient. This one's a priority juggler. If you remember, I'm a priority juggler. Priority jugglers have the attention span of a gnat. If you can't say it in 160 characters or less, you are not going to connect with 18% of the population. This is probably the longest email I've ever sent to a priority juggler. If you notice there's a sentence, there's 4 bullet points. And what's interesting, we put a little link here. Click here for a handy-dandy way to download a chart to manage your weight. Self-achievers and balance seekers, almost 100% clicked and downloaded. The other 3 groups had 0 clicks out of that 315. So we went into this saying, save your space. Stop putting in links. And there's 3 groups, they're never going to click. Here's 7 video links. You send that to me, I can't hit the delete button fast enough. You think I'm going to spend 20 minutes looking at a video? I'm a priority juggler. I'm a pretty smart guy. I already know what to do. I had a semester of biology in college. I should have been a doctor. That is how a priority juggler thinks. And Dan dealt with that for years. He started to go, now I'm starting to understand what Casey, why he is what he is. But this communication, I mentioned to you, we always like to put what we call an embedded action. We always put it in a different color. Hey, please click here and answer a couple of simple questions. So these questions, and I'm going to read it so I don't get them wrong. Do you have any shortness of breath when you're at rest? Do you have chest pain that doesn't go away? Do you have wheezing or chest tightness at rest? Do you have weight gain or loss of more than 5 pounds in the last week? Can you do normal things like cooking, showering, and cleaning? Well, the right answers are no, 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 yes. We never do all 5 no's or all 5 yeses. That's stuff we learned in kindergarten. And that's not from the data. That's just kind of being smart about how you ask questions. But a wrong answer to any of these questions tells me one of 3 things. They're drinking too much water, they're not taking their medicine, their activity schedule's off. Because what happens when we ask a patient, have you taken your medicine?
Oh, yeah.
Oh, yeah.
Yeah.
What happens? Are you drinking 2 quarts of water a day? Just, oh, yeah.
Oh, yeah.
We gave you this activity. Sure, we're doing that. And the next thing you know, 911, and they're in the hospital. What the heck's going on?
Dehydrated.
If any of you had a cardiac patient that came out of surgery and they're eating a Twinkie and drinking a Coke, and you're like, what are you doing? And this is a willful ignorant. Well, you got paid, right? Well, yeah. Then what's the problem? Well, you might screw up your heart again. Well, if it breaks, you'll fix it again, right? And they're just not connected. So for 27% of the population, that whole rational thinking just isn't there. Twinkie, so what if I eat a Twinkie? If it breaks down, you'll fix it again. My insurance will cover it. What's the big deal? That's just the DNA of that particular group. So again, we ask the questions, and I have some behavioral experts on the staff, to ask the questions in a way that's going to elicit a response that gives us a piece of information that kind of tells us what's going on. Now, growing up, my old man called it going in through the outdoor. If you ask people, are they taking their medication? Yes. But if you ask them, are you having trouble breathing or if you're gaining weight, it kind of tells you not to take a medicine. Well, Tina was the person running the call center, and she loves to tell this story because at the little summary meeting of 90% reduction, Tina stood up and said, I am the reason this program is successful. And everybody looked at me and said, well, Casey, what do you think? I'm like, I got to go with Tina. Because if she wasn't there to answer the phone and to teach people that were in trouble what to do, this wouldn't have worked. So any company that comes in and says, I have the answer to fix healthcare, I would really doubt that. It's going to put a number of different things together that's the answer. But the way we wired this program, she tells the story that, hey, it was Saturday afternoon, I was out gardening, I get this, she opened up her cell phone and she goes, oh, Bernie got a red light. She punched the button, went through a secure sign-in. She could literally look at how he answered the questions, punched the button and talked to him and said, hey, what are you doing? The guy goes, well, I'm about to call the hospital, I'm having a little trouble breathing. Well, do me a favor, dump out the pill bottle. How many are there? 30. Well, 5 of those should have been in your mouth because it's day 5. How much water are you drinking? 2 gallons a day, just like people. It's 2 quarts. You're drinking way too much water. It's filling up. That's what's part of the problem. You're having trouble breathing. Talk to me about your exercise. All I do is go get the mail. Well, if anybody's been to that side of Tennessee, about 2 miles outside of Nashville, the driveways are like this. And so the guy had a 400-yard-long driveway, was walking down it and walking back up it. And she goes, I'm going to call one of your neighbors and get your mail. She told that story and she goes, I prevented the readmission. And all I could do was agree with her. All I did was create the system that talked to this person in the way they wanted to be talked to, and then gave the electronic alert. Now, what does that alert look like? We created a dashboard for Tina. So in every day, so these are the 14 days, if there's a green light, it means the patient answered in a way that it's less likely that we're going to have a readmission problem. They're probably doing okay. And the good news is, across 315 patients, 14 days, that's thousands of boxes, 80% of these are green. 80% of patients do fine. They are following our directions. It's the 20% that causes the problems. And what this system did that we put together was just tell you which 20% is it, instead of who to go after. Now, this little dialog box, there's an open dialog box and with the check. The open means nobody's followed up yet. The check box means they have. And we have a little thing that says, what did you do? We push it back into the EMR. Pretty cool stuff happens there. So why did this work? I got the best content from the AHA. I got the psychographic thing that I knew how to influence patients 5 different ways. The discharge nurse got the person to fill out their name and answer the questions and tell them what was going to happen. That was pretty important. We had these automated workflows, and then we had the call center nurses. And let's say you're in a group of 2 or 3 physicians, you could set this up where your nurse handles this. Now, one of the favorite things that I have from this, we have a white paper that's out with the AHA on this particular topic. And Pat Dunn is the PhD that builds all of their care plans for all their 10 cardiac conditions plus stroke. Pat was like, it's important that we figure out how do we take science, traditional science, and then start to marry it with behavioral and consumer science. And when you do, there's some pretty cool things that can happen. Just a couple more examples. I'm going to take a very different one here, portal sign up. All right, we all try to get people to do MyChart and Epic. You know, whatever the system is, we got to get people to sign up. Well, we worked with a company called GEHA, Government Employee Health Association. And if you look here, they had about 2 to 4% of the people signing up for their health portal. We built a 5-week, 3-wave, 5-segment program to go, why should you care about doing this? So we just went to the root cause of the 5 segments to go, why care? And I just used all those same things that I went through when I talked about the 5 segments. What did we get? We got 80,000 people to sign up in 5 weeks. And like, well, how did you do that? Maybe you're lucky. Let's see if you can get those people to fill out their HRA. Well, we got 57% of them to fill out their HRA. Not on how you guys are doing, but most people are in the single digits with respects to getting people to sign up for portals. So we've used this for CHF. We've used it for portal sign up. Why is urgent care growing? Well, I told you earlier, one of the questions we ask is, how frequently do you go use an urgent care center? And what you're seeing here is 67% of all visits in the 1 to 3 month period is from this group called willful endurers. Well, gosh, if I have a practice and there's no willful endurers in the neighborhood, I wonder if that's why I don't have any visits. We did the same thing for emergency rooms and found it was 68%. Look at priority jokers. 0% of them have visited an emergency room in a 1 to 3 month period. They just don't use the emergency room. I mean, I'm sure they do if they get cuts and broken legs and stuff. But you will know people are starting to use ERs and freestanding EDs as primary care practices. And as an emergency room physician, there's a lot of people going, why are people coming here with coughs and colds? Because it says on the billboard there's only a 2-minute wait. I don't even have to call my doctor. My arm hurts. I'm going to, look, 2 minutes, I'm going to go do it now. That is a willful endurer, and the data proves it out. So what we did on Prove in the Field, I went to another large hospital system and I said, let's do a test versus control. So they sent out 17,000 emails on why should you care about us. They only gave us 10,000. You can see the openership. We had a little bit more, but I don't really care about openership. We had a lot more click-through rate, but the physical number of people who adopted and signed up for an appointment was 3x. Now, 200 appointments, if you cost it out $100, that's for what they paid me for this pilot. They made a lot of money on this. Here's one at a urgent care center in Staten Island. There's this gentleman that owns these few centers is very progressive. And what we did with this digital marketing, just telling people, I'm here, I can do green card physicals, I can do 2 or 3 different things. Well, his click-through rate, meaning when somebody sees an ad that pops up in it, they click through it to see what was the proposition. He was at 3%. We got him to 15% the day we launched it. Again, all we did was make a willful endure ad. Here, now, no wait. The second you get here, we're logging you. It was all about here and now, today, immediate gratification. Because again, remember the Twinkie example. It's about, I'm not thinking about tomorrow. Is that going to do harm to me? Well, I'll worry about that tomorrow. And when tomorrow gets here, it's today. That's a willful endure. And that's close to a third of our country. Now, where this got fun is we have one very large hospital system. It's over 100 hospitals. They have 71 urgent care centers. Well, some of them are massively successful with visits per day, and some of them are not doing very well. 8 patients a day, and they have 2 doctors on staff. They got to be losing hundreds of thousands of dollars. What they did was take all of their facilities, their freestanding EDs, as well as their urgent care centers, and did what I'll call a heat map. So all of the colors I showed you on the 5 segments are all very purposeful. Green for self-achievers, like green light go. Blue is passive. Purple is fierce independence. So we do a heat map for willful endurers. The darker concentrations are where we have more willful endurers as a percentage of the population. So they started to correlate volume with what's the distribution and the density of the population. And they found a correlation. Those of you that like to do regression analysis, which I'm not one of, but I understand them. Regression analysis and this R-squared analysis, all you're looking for is, when I look at any number of variables, what's the dependency of that variable to the success? And you can have dozens of variables that impact success, from location to, how much money do people have in the neighborhood. Well, we did this just on the 5 segments. So knowing that we had that data on urgent care, 67% are from Wolf-Linders, all they did was heat map Wolf-Linders, and they found an R-squared correlation of 0.33. What that means is 1/3 of the reason they're successful or failing is because of the location of that clinic with respects to the density of population of Wolf-Linders. So now let's look at concierge medicine. Do we know which one of these 5 groups have a preponderance to like concierge medicine? Well, I'll give you 2 examples. And Dan was a part of this way back in the day. He brought me in, and Joe King, who's over here, was one of the folks that was in the sales group at the time, one of the leaders. We looked at the country and said, at the time, where do these self-achievers live? There's a Dan's like, hey, Casey, we're going to expand the sales force. We've got to double the number of doctors. You know, this is the growth pattern of the company. Good luck. And I'm like, well, I'm not that good. I told him I was. But I said, let's go look at this data. So we literally mapped out the U.S. by zip code, and we used green because I wanted self-achievers. And I said, hey, Dan, there's a lot more self-achievers in Louisiana than there are in Manhattan. I'm going to put a salesperson in Louisiana because you better have good data, son. And so I showed him what we were doing, and we started to place some of this sales force. When I got there, we had 240 doctors, and I think 2.5 years ago, we were like 550 or 600 or something. So we had pretty rapid growth. But a lot of it was, if we find a doctor in these zip codes where people have a preponderance to join, and we get them to join us, people will follow. The second thing Dan did with the marketing function was we looked at the slogan at the time, which in 2008 was, don't worry, be happy. Well, I can tell you, people who are joining a concierge practice, don't worry. They are proactive. They're forward-thinking. They're planners. They think preventative medicine. And even, you know, so Dan's kind of like, hey, that message is 180 of what we should be saying. And then we came out with some, hey, cookie-cutter medicine would be a good thing if I was a cookie. They did some very creative stuff on the marketing side, which basically, and I know these stats because a couple of years later, I went to call in Novo Nordisk. And I said, do you know in 2012 we had more web traffic at NDVIP than you have at Novo? And do you want to know why that is? Because we know the preponderance of who has this problem. At the time I was talking diabetes, 80% of diabetes comes from 2 of these groups. So if you're going to try to change the game in adherence or holding on to a protocol, you better know which segment it is, and you better know how to talk to them if you think you're going to get them to the goal line. And so I gave you 3 different case studies there that are 3 very different applications. But so I think my last slide is, okay, now how does all this affect the concierge practice? And on the CHF, okay, what are the people doing when they're not in our office? How do I create a connectivity with this individual that looks like I'm with them 24/7? Now we have a better chance of doing that in concierge medicine than people do in a primary care practice where they're seeing 30 people a day. But there are dozens of applications of how do I stay connected with this patient? And if they answer those, how does it start to give back signals to me, like that dashboard where my nurse and my staff can take care of it? Because if we're all about getting people that next pinnacle of health, information is kind of key. So on the portal example, you just think about care gaps and notifications. I think most of us through our EMR have an appointment reminder system. They all have them, but we've got it 5 different ways. Our first client actually in 2014 was Nevada Health, which is primarily Hispanic and Medicaid. And we reduced our no-shows by 20%. Again, not necessarily a problem in concierge medicine, but if you start to think about, okay, that's an application there, what are the applications here? Now the last one is probably the one where there's probably the most correlation. So I just asked 4 questions here. Can I determine the segment that's most likely to want a concierge physician? Well, from the data, I'm way beyond can I. I know I can. I know which 2 groups it is. Can I do a heat map to determine the concentration of these people in my geography, both from a 5-mile and from a 10-mile radius? Concierge medicine has, general primary care medicine, people do not travel outside of 5 miles. But in a concierge medicine, I even know from back in the day, that's not necessarily the case. I drive 32 miles to mine, because I love the guy. 3rd question, can I determine the segment type by household? Well, today, if you gave me a zip code, I can literally, on my iPhone, pull up and give you the density of the 5 segments in that particular zip code. And we can go all the way down to the household. So we have 230 million people in the US already pre-tagged. So that goes to the last question, can I do one-to-one marketing to grow my practice? The answer is yes, but here's where the kicker is. Dan was, beforehand, he was, well, what data do you have? I have the data that says this should work from a consumer standpoint. From a concierge standpoint, I've not proven this in the market yet. Now, do I have enough other data to go, yeah, it's going to work? Absolutely. I'd stake my career on it. It's going to work. But I haven't done it yet. And so one of the things, and one of the, why I love the association with concierge medicine today is Michael's a pretty forward-thinking guy. And he's like, Casey, we should probably, I want to introduce this concept, and then we should probably go some places and try it. And then at next year's meeting, let's talk about, did it work? Your healthcare message to the individual in a way that's going to matter to them. What's the frequency, the media choice, the colors? I think inherently, empirically, we all know that's the right thing to do. And as physicians, when I went through those 5 segments, there's none of the stuff you haven't already done. It's just how do we compartmentalize some of that thinking to be incredibly specific towards what we do. So with that, I'm going to stop and to see if there's any questions.
Yes, we have time for 4 minutes for questions.
Oh, 4 minutes.
So,
And I'm going to hang around for a while too. So if there's people that want to chat more, I love this stuff.
so I just also want to say, as you're thinking about what your question is going to be, so come on, it works. All right.
Some of you already texted me. JT, you must know my cell phone number.
So for a long time, concierge medicine today has been hearing from doctors, I need more patients. I need more patients. You're no longer, like we talked about a little bit yesterday, how do we find a doctor? It used to be we pull out the HMO, PPO manual and kind of cover our eyes and just go like that. And like, oh, all right, that one's in my zip code, I'll go to him or her. And this really reverse engineers that. And when you and I started talking a few years ago, and Dan, thanks for the introductions too, this just made total sense. Like, it's from a marketing perspective and a public relations perspective, which is I kind of geek out on stuff like that. It's not just sending a bunch of postcards out to a bunch of zip codes and names you don't know. It's much, much, much more detailed than that, because we now know what psychology behaviors are attracted to certain health habits. So if we have a homeowners association or a neighborhood with 500 homes, we all know that if we send a postcard to 500 homes, we might get maybe 17 or 27 calls. But what if we knew exactly who had these health habits that is attracted to these types of practices? Then we can move the needle and really get people interested in what you're doing. So my question is, when can we move from what you're doing with big organizations and big data to move into more private practices, individualized, in the next couple of years? And we're 5 years away, or are we a year away? What's your thoughts?
Couple days ago. So we have enough, I mean, we've done things with standard medical practice. Again, the whole platform is built around acquisition of new patients. How do I keep patients loyal? How do I clinically get them better? We've just gotten into the collection space and had some pretty significant impact on people paying their bills. But acquisition is what you're talking about. We've got a lot of that built right now. As I mentioned earlier, I'm a data guy. We just have to go prove it in this space.
Yeah.
So the ability to do it is, I could start this afternoon.
Yeah, and when yes, come over here.
What are the 2 types of patients that most likely? Maybe I missed it, but what are the 2 types
Oh,
of
well,
patients?
that's the secret. You're going to have to talk to me later about that. Now, if you look at that group, self-achievers, you think about the nature of who they are, and I would say Joe King is a self-achiever as well. This is about prevention. It's about winning. It's about having a plan. It's about understanding, about being close to my doctor. That's the DNA of a self-achiever. The other group is priority jugglers. I don't have 10 minutes in my day to talk about this or that because I'm juggling so many priorities.
I just took your test, I'm a priority judge.
80% of physicians are priority jugglers or self-achievers. Interestingly enough, almost every Catholic priest I've ever tested is a balance seeker. And so as I'm working with different church organizations, it's like, well, balance seekers love to tell you everything they know, but the other 80% of people don't want to be talked to like that. So is that part of what's happening? We're trying to answer that, but those are the couple of things.
So yesterday we went from trying to go back to the future, or can we go back to the future, to this year, to today, can we predict our future? And psychology, behavioral habits in healthcare, that is where we're moving towards. That is where 2019, where you are going to be making a difference when we look at things like this. And this is something that you can talk with Casey about today, something you can talk with him about in a year from now. And we've actually, CMT has looked at some certain zip codes, and it's amazing to see, wow, these 9 zip codes that this concierge doctor has in this particular area have tons of people. So you can almost predict the future of whether or not a practice is even going to be successful in that area. So this is stuff that really is moving from, are we going back to the future? Can we go back to the future? To now we are now predicting our future. So thank you, Casey, for your vision for this space and for your vision in this data. I'm a total geek, like he's a superstar to me, so.
And it's a priority group, I love to hear it. So thank you very much. Again, I'm going to hang around. Yeah, I'll just be out there, and anybody wants to talk or chat or has questions. I went way too long, and he told me to leave 50 minutes for questions, and I messed up.
You're good.
So I'm going to hang out.
So we have a 10-minute break, and then we have our legal session coming up. I know everybody's going to be sitting on the front row for that. Everybody's moving up. So Jim Eichen will be starting here in 10 minutes.
Just some of the most impressive and really cool things that you've ever heard. I know I get geeked out about it, and I'm so excited. And so if you want to connect and learn more about this, I can send you a white paper, and I can connect you with Casey and get started learning more and talk with Casey more about how this could really, fit for you and learn more about it. So if you're interested, email me at editor@conciergemedicinetoday.com, or you can go to our website, conciergemedicineforum.com, and let me know that you want to learn and get connected with Casey, or get connected with maybe one of our other speakers. And look forward to seeing you next October at our next Concierge Medicine Forum. If you're interested, hit the subscribe button. We'll see you later.